Dr. Adkav is a robotic joint replacement surgeon and he's the chairman of Saishri Vita Life Hospitals. So please welcome on the stage.
Dr. Antonia Chen, she's on her way, and we thought we should start even if the delegates will keep joining us. So ERA's protocol, so total knee and total hip replacements are now time-tested, surgeries, and expectations from patient, they have gone up. So.
Hello.
So we inject these cocktails and details about this Dr. Avinash Pare also, he's an anesthetist, he'll be discussing with you. So all these cocktails we inject in the posterior medial space, posterolateral, in the medial gutter, lateral gutter. After the orthotomy closure, we inject intra-articularly and then subcut and subcutaneous plane also. So this definitely makes, this surgery to a certain extent, painless experience. After this, we go for adductor canal block. And then we also, keep epidural catheters. So we believe in multimodal analgesia, and this has really helped us. So all our bilateral total knee replacements, we are able to send them home within 48 hours. Couple of single total knee replacements, we have discharged them in 24 hours as well. So after the orthotomy closure, sterile dressing is applied, and now anesthetist is injecting, this in the adductor canal. So there are two options. So surgeon can inject under vision directly in the adductor canal. That is one, thing which is followed in various centers across the world. Otherwise, under sonography USG guided, anesthetists can inject in the adductor canal. This really gives excellent, pain relief, analgesia post-op. So this is a typical range of movement which we observe in 24 to 48 hours. And that is possible because of the analgesia with this multimodal analgesia protocol. That's 48 hours ROM, active ROM. Once patient is home, another patient, bilateral TKR, 24 to 36 hours post-op. Good range of movement you can see. So we believe in aggressive mobilization after the surgery, and that's the active ROM for bilateral total knee replacement, and that's how patient is mobilized. Some of them are able to walk without any support with just knee braces in 48 hours. This is around 3 weeks. and couple of patients staircase climbings around 3 to 4 weeks post surgery. For hip, we gave fascia iliaca block, and that has given excellent pain relief for almost all the patients. And actually, we can inject this before induction also. So because many times fracture neck femur patients, it is difficult to give them proper position for spinal epidural. We can inject this under USG guidance, and then they are comfortable, and where we can give them proper position for spinal epidural. So Dr. Avinash Pare will be discussing regarding this in detail. So that's a bilateral avian patient, and we did it under Willis hip AR system, and that's post-op, and we could mobilize him after bilateral THR. This is just 24 hours video after bilateral DA THR. So as far as closure is concerned, Stratafix, we have started using it, and that really gives good, secure fixation and leakages after the wound, because that is one of the common reason cause for developing prosthetic joint infection, and you need repeated dressing to prevent any infection. So to stop leakages, Stratafix really helps. So I hope this video is clear, and I'm going to show you a company animated video also, which is pretty clear. And Dermabond Preneo, how many of you used Dermabond Preneo? So we use it regularly, and this really gives good cosmetic closure, and we can avoid pain while patient feel while removing the staples. So that's a adhesive glue is applied over this dressing, and this really works well. And while removing the this adhesive dressing, it is pretty easy and painless experience for the patient. So this is actually a J&J Ethicon video. Can we have?
There are two options for where to seat the tab when initiating the closure. In the first technique, the fixation tab is seated above the apex of the incision. To begin, take the first pass in intact tissue directly above the apex, in a direction away from the incision. Pull the device through the tissue to gently seat the fixation tab. The fixation tab should be seated above the tissue plane so that it remains visible. Do not exert additional force on the fixation tab or device. Moving toward the apex of the incision, take a pass in the intact tissue perpendicular to the initial pass to lock the stitch. Multiple passes are acceptable. Gently pull on the device to take up any slack. In the second technique, the fixation tab is seated adjacent to the apex of the incision. To seat the fixation tab, take the first pass in intact tissue adjacent to the apex in a direction away from the incision. Pull the device through the tissue to gently seat the fixation tab. The fixation tab should be seated above the intact tissue so that it remains visible. Do not exert additional force on the fixation tab or device. Moving toward the apex of the incision, take a pass in intact tissue perpendicular to the initial pass to lock the stitch. Multiple passes are acceptable. Pull gently on the device to take up any slack. Regardless of the initiation technique used, the remaining closure steps are the same for both. Proceed with a continuous suturing pattern to close the incision, taking opposing bites on either side of the wound in standard fashion. To achieve the desired approximation and tension, gently pull on the device with each tissue passage. Continue approximating along the length of the incision, taking care not to over-tighten the device. Retain approximately 3 inches or 8 centimeters of the device for completing reverse stitching to secure the terminal end. To complete and secure the closure, take 2 passes in the reverse direction across the incision. Then, gently pull on the free end of the device and cut flush with the surface of the tissue. Closure is now complete.
So this is, pretty easy. It saves time, and because of the device, I mean, you get real, watertight closure. And for the Dermabond, we'll just watch this video. Although there is no audio for this video, and so once you have closed the deep tissues, subcuticular, subcut and subcuticular, on this skin surface, you apply this Dermabond Preneo, and then you can apply the glue to secure it to the skin surface. Before you apply it, make sure that surface is completely dry, and then you start applying it. So again, this also saves a lot of time, and usually actually in our practice we do proper subcuticular closure, and we don't rely on this for approximation. So we do subcuticular closure, but this is one good tip in this video where we can actually put it on one side and we can approximate and then apply the glue. So this really gives good cosmetic closure, and also, although company claims that we can allow patient to take bath, but we don't suggest them. We ask them to maybe take it after 10 or 12 days, not immediately. As per company record, and there are various studies that we can allow them to take shower, and then this is completely waterproof and works really well. So once we apply the glue, allow it to dry for a couple of minutes, and then we can aggressively mobilize the patient, mobilize knee, hip as per our routine protocols. We don't need to change our post-op protocols with this technique. Any questions from anyone regarding this? So we have started these ISH cases affiliated fellowships at Sai Shri Vita Life. Thank you very much. Presentation.
Hello, hello, okay.
Okay. Good morning everyone. The other day I saw a patient for pre-anesthetic checkup, and she had undergone knee replacement of one of the knees 4 years back, and then she was advised the surgery for the second knee immediately within a month or so. But she had such a severe post-operative pain that she avoided the surgery for 4 years. So that is how important post-operative pain management is in all these patients. So I'll be talking about the post-operative pain management in the total hip and total knee replacement patients. As per the ERAS protocols, this is a short introduction about the ERAS. So the ERAS protocols, they recommend to minimize the stress response to surgery, to optimize the patient preoperatively, speedy recovery, and early recognition of complications. So I'll be concentrating mainly on the pain part. So the pain part involves three parts. It's the preoperative period, the intraoperative period, and the postoperative period. In the preoperative period, this is something called as preemptive analgesia. So we block the impulses which are going through the pain pathways to the brain, which hypersensitizes the brain. So if you block these pathways, the post-operative pain of the patient reduces. So what we are doing is we are giving NSAIDs like diclofenac or aceclofenac if they are not contraindicated, regular use of paracetamol preoperatively, and if NSAIDs are contraindicated, then we are using tramadol in the preoperative period. In the intraoperative period, what we prefer is a regional anesthesia. We use combination of spinal and epidural anesthesia. We avoid the spinal opioids because they can cause urinary retention also, and they can cause the cognitive impairment also in the patients. And the ERAS doesn't recommend epidural, but we are using epidural because few of the patients were very demanding and they wanted pain relief throughout in the post-op period. So as Dr. Adkar described, we are infiltrating, after the implant is in place, we are infiltrating the joint capsule, the soft tissues, and the subcutaneous tissue with local anesthetic. So what we are using is ropivacaine 0.5%, and we add to it tranexamic acid and ketorolac. Earlier we used to add adrenaline also, but we had few issues with adrenaline when we added adrenaline, so we've stopped using adrenaline now. So most important part is the nerve block techniques in the post-operative period. And earlier people used to use femoral nerve block, but there were issues with quadriceps weakness associated with femoral nerve block. So now the gold standard is the adductor canal block for total knee replacement, and fascia iliaca block for the total hip replacement. So this is the demonstration of adductor canal block. So adductor canal is the space between the sartorius and adductor longus, and laterally there is vastus medialis. So we keep the hip abducted and the thigh externally rotated. We keep the probe on the mid-thigh region. This is the femoral artery that you can, the circular structure you can see is the femoral artery. The femoral vein is just adjacent to it, but most of the times it's compressed. And lateral to the artery is the saphenous nerve. So this is vastus medialis, adductor longus, and this long muscle above is the sartorius. So it is very important that in addition to saphenous nerve, we also block the nerve to vastus medialis because it is supplying the anterior and medial portions of the knee. So just injecting lateral to the artery won't suffice. You have to also inject below the fascia below the sartorius muscle. So this is the needle coming in, and when you get a pop, you can see the needle just lateral to the artery. This is the needle coming in. And there's a pop there. So you aspirate and inject about 20 cc's of 0.5% tropivacane. We also add dexamethasone to the injection. So it just prolongs the action. So what I was talking about was the blocking of nerve to vastus medialis. So this is the fascia. Anyways. For hip replacements, we are using the fascia iliaca compartment block. The fascia iliaca is the fascia covering the iliacus muscle in the pelvis. It gives a very good pain control. It reduces the opioid requirement. There is less incidence of post-operative nausea and vomiting and faster recovery in hip replacement patients. So this is the fascia iliaca block demonstration by USG. This is the brim of the pelvis. This is the iliacus muscle, and the fascia covering that is the fascia iliaca, which separates iliacus from the abdominal muscles. So what we do is first we palpate the anterior superior iliac spine, then keep the probe just medial to the anterior superior iliac spine, and then move it a little caudally, then you can see this pelvic brim, this semicircular structure that you can see is the pelvic brim. And then we insert the needle from below towards cranially, and just below the fascia, we inject the drug. It is important the drug is injected in the right plane. It should not go in the muscles. It has to be below the fascia. So the first part when he tried injecting, it was in the muscle, so it's reinserting the needle now. When you are in the right plane, you can see the muscles separating, and that's the right plane where we inject large volumes of local anesthetics with, of course, dexamethasone to prolong the block. So the principles of ERA's protocol would be multimodal analgesia, starting right from preoperative period, using regional techniques for anesthesia as far as possible, and nerve blocks, obviously. In addition, we are also using epidural for rescue pain and better comfort of the patient. One or two points, in addition to all these methods, there are people who are using a small dose of ketamine intraoperatively. So ketamine blocks the NMDA receptors, and it avoids the hypersensitization of the nervous system, which reduces the post-operative pain. Few people also use IV DEXA in addition to prolonging the analgesia of analgesics. It also reduces post-operative nausea and vomiting. Earlier, people used to use gabapentins and pregabalins, but they cause cognitive impairment, so we are not using it we are not using the gabapentins and pregabalins anymore. So the basic principle is opioid sparing analgesia, avoid the drugs which cause a cognitive impairment, and give better comfort to patient, avoid drugs which cause post-operative nausea and vomiting. These are the protocols post-discharge, 30 days follow-up, phone call after 48 hours to see the comfort of the patient, 7-day clinic visit, and any emergency visit. Thank you.
I take this opportunity to welcome Dr. Antina Chain to City of Pune, India, and thank you. So I would like to request all the dignitaries from Maharashtra Orthopedic Association, Pimpri Chinchwad Orthopedic Association, Pune Orthopedic Society, for please come forward. Antina Chain will just do formal inauguration of this course with lamp lighting. Please join us, please. Yes. Dr. Karne, please.
I request everyone to please come on the stage. We'll take a group photo. Paresh sir, please come on the stage. Patil sir. Dr. Karne, please stay on the stage. We'd like to felicitate Dr. Antonio Chen. Adkasa, please be on the stage. We'd like to invite Ms. Jackie Gordon, please come on the stage for your felicitation. Dr. Rajiv Niramne, please come for the felicitation. Kunal Bansal, sir, please on the stage. Karne sir will like to felicitate you, sir. Please come on the stage. Patil sir, even you come on the stage. Paresh sir, please come on the stage. We'd like to felicitate Dr. Kunal Bansal, sir is the Secretary of Pune Orthopedic Society. Patil sir, please. We'd like to felicitate Dr. Rajiv Niravne, serve as the Secretary of Pimpri Chinchwad Orthopedic Association. Paris sir will felicitate him.
So they were a bit curious about this tradition of lighting the lamp. So it is about spreading light of the wisdom and spreading this information. So that's the thought process behind this. So, and this is traditional Indian way of starting any auspicious auspicious way of starting any function. So without further ado, I would like to request Dr. Antina Chen to deliver a talk, and that will be followed by panel discussion. We are looking forward to your talk. Thank you.
We'll quickly like to introduce Dr. Antonio Chen. She's MD MBBA and she's the president of American Society of Hip and Knee Surgeons. She is the professor and chair of Department of Orthopedic Surgery at UT Southwestern Medical Center, Dallas. She is the youngest surgeon and second woman to take the reign as president of the American Society of Hip and Knee Surgeons. Welcome, ma'am.
Thank you so much for having me here. I'm truly honored to be here, and thank you for spending your Sunday here with us learning. So ERAS is great because it's not just one country that does this, but every country does it, because we want the best outcomes for our patients. So talking about improving joint outcomes after total joint arthroplasty, I'm going to focus on the preoperative and intraoperative space with ERAS, hemostasis, and wound closure, and then postoperative surgical site monitoring. So what's the concept of marginal gains? Who here ever gotten a bicycle before? Anyone here ride a bicycle? Okay, lots of bicycles before, right? So the British cycling team back in the 1800s hadn't won anything for 100 years, or sorry, they won one gold medal over 100 years. They brought in a new person. His name was Dave Brailsford. And over the next years, he did something called marginal gains. He had small little improvements over time, which then improved the outcomes of his bikers. So what did they do? They changed their bike weight, they changed their sweep quality, they changed their mattresses, hand washing, tire grip. All these different, very small changes led them to win 5 Tour de France titles in 6 years. So needless to say, we in orthopedics like to do the same thing. We make small little changes. We just heard an excellent talk about neuroaxial anesthesia, about doing blocks. I never used to do those before, but it has changed over time to improve our patient outcomes. So we already know the purpose of ERAS, and the idea is to work together with our anesthesia colleagues, with our nursing colleagues, everyone in the hospital together to give a better outcome for our patients. So what does that look like in hip and knee replacements? So we screen our patients before surgery. Remember, there's a preoperative, intraoperative, and postoperative phase. Our preoperative screening, we look for smoking, and we do ask them to stop smoking before surgery. It's not always possible. If you can get your patients to stop 4 to 6 weeks prior to surgery, their outcomes of infection go down. Hemoglobin A1C, diabetes, is very prevalent in the US and in India. So we actually look at a cutoff of a hemoglobin A1C of 8 for our primary joint replacements. In the US, we have high BMI. You guys don't have as high BMI here, which you're lucky with, but we have a much higher BMI, so we try to do under 40 to reduce the risk of infection. Albumin is something we're looking for. We talk a lot about protein now. Albumin under 3.5 is ideal. And then hemoglobin less than 10 probably should be seen by a specialist to understand why their hemoglobin is like that. It might be consistently like that for their whole lives. And then lymphocyte count is another one. So what do we do before surgery? We do a HibaCleanse shower 2 days prior to surgery. In our country, you can buy that from the drugstore. You can probably buy that here very easily too. And just wash your body, just getting a good clean area. We give them exercises, and we have them meet with physio beforehand to make sure they can do the exercises. And then we do a total joint class in education. Very similar probably to you guys here. We do a lot of checks. Vitamin D is something that we regularly check for. I recognize vitamin D is a very expensive test to do here, so sometimes you just supplement it. But osteopenia, osteomalacia is very common here in India. And in the US, as we get older patients, especially our female patients, our vitamin D levels tend to be low, and we don't get a lot of sun outside. So that's something to look for as well too. We do betadine swabs in the pre-op area to reduce infection risk, and then we do another skin prep at the time of surgery. We ask patients to wash beforehand, but they don't always wash. So we wash them again in surgery, right before surgery. And if they're older patients, above 85 or 70 with any of these conditions, we send them to what we call as geriatricians, doctors who specifically look at older patients to optimize them prior to surgery. So we have them stop 8 hours before for solid food. But 3 hours before surgery, before the 3 hours, we allow them to drink clear liquids. What we actually find the best, water is good, but only okay. We actually like our patients to drink coconut water. They don't like getting Gatorade, they don't like drinking Powerade or the drinks, they're very sugary. But coconut water is actually very high in electrolytes. A can of coconut water has more potassium than a banana. So that's something to think about for your patients. Minimize sleep aid sedatives and hydrate before leaving home. We say 3 hours because if you show up and your surgery is earlier, then you can still go to surgery. And then we give acetaminophen before surgery. That's the only one, or paracetamol. And we hold NSAIDs and narcotics prior to surgery. We do the same thing, neuroaxial anesthesia. Now our neuroaxial has changed. I used to use bupivacaine for all my cases, and now for my faster cases, I'll do mipivacaine. It's shorter acting, which means they can move faster, but you have to operate in that time frame. So that's something to be careful about. But we use more and more mipivacaine that had less reactions and side effects to it. Only general anesthesia occasionally. So blood loss reduction is a big area as well too. Who uses IV tranexamic acid? Okay, very common worldwide now, which is great. Anyone use oral tranexamic acid? And then topical? Topical, okay. So topical, we only use it if their patient is like a DVT, PE history, but most of the times we give IV. We don't use oral as well too. It takes too long to sit in. That said, one of the biggest things I found with my patients, especially knee surgery patients, they get hematoma afterwards. And with that hematoma, that's the bleeding that happens and restricts their range of motion and the recovery. So I've been using what's called Surgicel powder, which is an oxidized regenerocellulose, only within the last year. And what it does is it's a powder. I open it up and I use it throughout the case. So I can use it multiple times and just use one vial the entire case. The clot remains stable even if you irrigate. It's fully absorbable, and what I really like it too is I tried to do infection reduction in all my patients. When you use this agent, it reduces the pH level, which makes it harder for bacteria to grow. So it is bacterial, it inhibits bacterial growth. So that seems to be helpful as well. So for intraoperative care, I'm going to go into greater depth here about each one of these. I'm going to cover each one of these issues in the next few slides, but it gives a nice summary of the different ways to reduce wound complications. And the focus here for me as a surgeon is what can I do for my patient? I can't get my patient's sugars to go down or have them be better at diabetes, but I can control these areas of intraoperative factors. So why a multi-layer closure? A multi-layer closure allows us to close the wound tightly, and you think of the arthrotomy, right? So for the knee, for the hip, you want to close the arthrotomy. This study found that using barbed sutures and topical adhesive with mesh leads to less adverse reactions. So for less reverse events, what does that mean? Patients can move more securely postoperatively. So your patients have better range of motion than our patients. They want to bend their knee all the way, right away. You can do it with a watertight closure. And there's no need to return to the clinic for a staple remover. And that used to be the thing. I'd have to see patients every 2 weeks after surgery to take their staples out, and then they were in a lot of pain afterwards. They didn't like the process of taking the staples out. So if I didn't have to take the staples out, run a suture in there, created a watertight closure, didn't have to take the staples out, and the cosmesis looks nicer. Lower hospital costs as well. Again, lower readmission, lowest reoperation, shorter length of stay, and more likely to go home, although that's probably more common for you guys to go home, using a watertight suture closure. This is the study looking at multiple different studies together. There were 22 randomized controlled trials and 18 observational studies. And what did this study show? The study demonstrated that if you had this, you again use barbed sutures and you use topical skin adhesives and with polyethylene mesh, and that improved your outcomes after surgery. So the question always goes, I'm going to show you what I used to do. I used to do interrupted vicryls for my arthrotomy, and I switched to barbed sutures. So has anyone here been to Wrightington before? Wrightington is the birthplace of the total hip, right? John Charnley did it. So I went there and I saw someone do a troch flip osteotomy, the oldest approach in the book, and then closed with barbed sutures. So I came home and I changed my practice immediately. This is a study where they compared the barbed sutures with interrupted vicryls and found that the barbed sutures, so you had a knee model, you did barbed sutures in one and you did interrupted vicryls in the other. They were both challenged with fluid into the joint itself, and they saw how much fluid came out of the joint. There was less fluid that came out of the barbed suture. And the reason that matters is because, again, you have a watertight closure in there. It's unlikely to disrupt and cause an arthrotomy problem when the patient moves a lot, which also keeps microbes from going in, reduce infection risk, but also allows the patient to move more securely. So this is a cadaver study that they did that I thought was really interesting. Spiral and symmetric, two different ones. We're going to be able to experiment with them outside, which is great. Similar outcomes, same cost, but a faster closure. So on the arthrotomies, the symmetric are what most people use because it's a thicker, stronger one under high tension areas. The spiral, the nice thing about it is if it's bidirectional, two people can sew at the same time. So I'm going to show you some videos of us sewing two different directions. So this is my personal thing. When I used to close with number 1 vicryl interrupted for fascia. If there is a large adipose layer, I would close it with number 1 vicryl, 2O monocryl interrupted, and then 3O monocryl running. Since then, I have changed because I wanted that wider tight closure. I do tack down with some vicryls first, and then I run the Stratafix bidirectional because that way two people can close at the same time. And then if there's an adipose layer, I'll show you a nice way that it really brings the adipose tissue together. Then 2O monocryl interrupted, and then 3O Stratafix monocryl, which we're going to be able to try in the lab right outside, which is nice. Actually, this one doesn't have the videos I saw. So there's a videos that I have. I can probably pull it up on the other one that shows this, that shows the closure pretty nice if you want to see videos of it coming together. So why do I not use staples anymore? When I was in training as a registrar, I used staples all the time. This is a study out of Mayo Clinic. This is 45 patients. Every knee patient got arthrotomy and deep fascia treated with number 0 vicryl interrupted. Subcutaneous layer was interrupted 2O monocryl, and the final layer was randomized to 3 different groups. One group got subcuticular closure, the 3O monocryl, then vertical mattresses, and then finally staples were the 3 options. And they use this special angiography. So this is a vascular surgery device. What it does is it allows you to look at the blood flow. And what the study found that if you use running subcuticular, you had better blood flow. If you use vertical mattress, you had the worst blood flow. And if you had staples, you also had pretty bad blood flow. We need blood flow for our skin to heal, and we need our skin to be able to approximate together. So this made me switch more to the subcuticular because by doing so, I had better blood flow to the skin. So dark area is actually not good, lighter area is actually better. So better blood flow in those areas. So we did a consensus statement with the European and US surgeons, and we came up with a few consensus statements. This one's specific to total knee, and I'll show you from total hip, although they do cross over. So for total knees, close the wound in semi-flexion versus extension to provide for superior range of motion. Close the wound in layers. The use of subcuticular sutures over staples lowers the risk of superficial infections and higher patient preferences. It does take a little bit longer, but not that much longer. For the hips and knees, use triclosan-coated sutures over non-antimicrobial sutures. So the idea is triclosan is an antimicrobial agent. It's not an antibiotic, so you don't have to worry about resistance, but it kills bacteria. And then use barbed sutures over non-barbed sutures to lower wound complications, provide better cosmetic appearance, lead to shorter closing times, and provide overall cost savings. We all have our patients. All they do at the end of the case, they care about is what their wound looks like. They don't really care about what you did inside. You did a beautiful hip, beautiful knee. All they see is the wound. So cosmesis actually does matter to our patients. For adhesives, when I do the running 3.0, I use Dermabond versus staples. This is a study that showed that staples had increased tape blisters and skin abscesses. And we'll get to play with this afterwards as well too. Something that changed my practice here is I went from direct lateral for total hips to direct anterior. And with my direct anterior hips, I was noticing some wound issues proximally. So I switched actually to these mesh adhesives and then with the glue on top of it. And I will say that it has reduced my wound complications by far, higher patient satisfaction, and lower rates of readmission, typically for wound issues. So that has changed my practice in all honesty. Occlusive dressings are important. So I send my patients home with an occlusive dressing. They can shower right over it. They love that. When you do so, shorter length of stay, more discharge home, and less readmission, which potentially can lead to some cost savings. What's important to me, and here's a video that hopefully plays here. So I close my wounds. Antimicrobial delivery is a big thing, right? So I want to use triclosan-coated sutures. So the plus sutures is what I really like to use. I like to seal the wound. So here's an example of me at the end of the case after running it. This is a big knee, not a hip, surprisingly. And then you run the 2.0 Adcent over that, and you run that there's no way to get into it, so it's a watertight seal there. And then creates a barrier for microbes to enter the wound. An occlusive dressing afterwards adds an additional barrier and makes sure that patients don't touch their wounds. I'm sure your patients go home and are very good patients and don't do anything to their wounds. Mine are not like that. Mine will touch and pick at the wounds, and so I don't want them doing that. So intraoperative care, very similar things to you guys. We do normothermia, glycemic control, euvolemia, and try to reduce postoperative nausea and vomiting. Dexamethasone is something we give to our patients, except if they're diabetic and bipolar. And then what happens is I no longer use a Foley catheter. I used to use a Foley catheter every case. Now you guys probably don't either. Big change. When I was a resident, everyone got one, and now no one gets them. And then we use DVT prophylaxis, typically use aspirin. So probably very similar to you guys in your practice as well too. So this is our whole pain floor management. I'm not going to read it all. If you're interested, you can take a look at it. But we do have some access to narcotic medications, and we can send our patients home with it. We might be different from your patients. So it does make a difference in outcomes. We like using Toradol as long as they are not contraindicated to NSAIDs, because it's an IV medication that's not a narcotic. Acetaminophen is around the clock. Celecoxib or meloxicam, around the clock. They take it no matter what. Tramadol, and we take the celecoxib or meloxicam with our aspirin. Tramadol is what we give in certain patients, and then we give oxycodone at a higher dose for next level of pain. We very rarely use hydromorphone, almost never. Only patients who are opioid, on chronic opioids do we use hydromorphone. And of course, there's other ways. We give everyone ice therapy. When they come out of the operating room, we put a pad on them, and we give everyone ice therapy after surgery. And then bowel regimen, of course. Discharge criteria, very similar between countries, I'm sure. They can be medically stable, can ambulate, tolerate oral diet, independent with transfers, and independent with stairs. So a lot of our people live in stairs, so you have to have stairs. You have to be able to go up and down stairs before you can leave. This is purposely busy. You don't have to understand every single one of it. Patients are very scared. They go home and they have 8 pills, bottles of pills. And how do they take them? When do they take them? So this gives them a sample schedule of when they should take their medication, how they should take it, things like that. This includes Dilaudid, but we typically use oxycodone for it. So how do you monitor patients after surgery? And this is called something called surgical site outcomes. So when it comes to surgical site outcomes, we almost always think about infection. And so you think of the CDC wound classification definition, it's typically clean versus contaminated, so that's dirty. And the current classification systems are too general. So why do we need a new classification system? Well, if you have a patient that has a complication, and I have a patient that has a complication, we need to speak the same language. Doesn't matter what country you're in, doesn't matter what language you speak. I appreciate you understanding my English because my Hindi is not good at all. But it's one of those things where we want to have a common language for what we treat how we treat our patients. So what do? We wanted to come up with some that didn't make postoperative complications scary. The problem when you say surgical site infection, things like that, there are negative implications, difficult for surgeons to admit they had a problem, and difficult to gather reliable data. That's how we can talk across the world. So I'm going to break this down, I promise, but you can see this is the entire thing here. What we've come up with is a classification, not just looking at infection, but at multiple different areas. So the D stands for dehiscence, the I stands for infection, the S stands for seroma, and the H stands for hematoma. So how is this based on? The different part about this classification system, it's not based on what the wound looks like, it's based on what you did to the wound. So what does that mean? This is the clinical intervention, and that's the QR scale for the whole code. So I'm going to steal a microphone, actually. Thank you. Perfect. Okay. So for clinical intervention, remember, how we're using DISH is what did you do for the patient, right? So if the patient comes in and has no problems at all, then the answer will be D0, I0, S0, H0. So everything 0 means no problems. Great patient. This is every one of your patients. Just kidding. I wish. So the next one is 1, which is patient self-monitoring, meaning the patient calls in and says, my leg's a little swollen or it's a little red. You're like, I'm not worried about it, but the patient should monitor it. So that would be D1, I1, S1, or H1. Then you go to 2. 2 for dehiscence is a local treatment. They come to clinic, there's a little bit of opening, you put some steri strips on, or you debride a little bit and you put some nylons on. But you do it all in the clinic, it's very local, right? For inflammation, now you're a little bit more worried, right? For the infection standpoint. Okay, your redness is a little more concerning, but I'm gonna keep watching it, right? Or I'm gonna do something sort of more, I'm not gonna do anything surgical. Let's say I give you antibiotics. That's healthcare monitoring as well too. I'm giving you antibiotics, oral antibiotics, send me pictures. Seroma, hematoma, healthcare monitoring. If you keep going up to 3, for dehiscence, it's surgery without reconstruction, so no plastic surgery needed. For I, it's surgery with local anesthesia, seroma, local treatment, and hematoma, local treatment. So a seroma local treatment would be interventional radiology. They put a drain in, and they just let the fluid out, for example. We don't see this as much in orthopedics. It's mostly our general surgery colleagues. And that's the other thing with this classification system. It is not just orthopedics. It's also general surgery, cardiovascular surgery, thoracic surgery, etc. And the final one is the worst case scenario, right? You take them to the operating room, you reconstruct for inflammation, infection, seroma, hematoma, you go to surgery, and that's under general spinal anesthesia. So that's how the classification works with regards to clinical intervention. The next one is clinical presentation. Now, the clinical presentation is not always available, and it's not as important. What it looks like and what you do can be 2 very different things, and I'll explain it in just a little bit. So as you can imagine, this is A, B, C, and D. A is the least concerning, and D is the most concerning, all right? So you can see here like septic shock, sepsis, things like that. That's D. That's the worst presentation, and then A is the least concerning presentation. So let's see what this looks like. So how do you use it in practice? We just kind of walk through it a little bit. So we have a show called Wheel of Fortune. And what you do is you start here and you show what happens from this end to this end. So is dehiscence present? If no, 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 you can see the score would be D0, I0, S0, H0, right? Now if dehiscence is present, what did you do to treat it? So you'd have a number after it followed by a letter. So for example, D1A. For the I, what did you do? What was the presentation? And you choose it there. Same thing with seroma. Is it present? Yes. What did you do? What was the clinical presentation? And then you go ahead and write your letter there. And then H is hematoma present. What did you do for it? How did the patient present? And then you get a number at the end of it that potentially looks like that. So it sounds complicated, but after using it a few times, it's not bad. So here's an example. Probably very similar to what you have in practice. 62-year-old female, type 2 diabetes, BMI 28, underwent elective total knee replacement, discharged home the next day. On day 7, the patient came to clinic with localized erythema and wound separation of the incision with superficial skin. There was bruising and swelling of the knee with minimal pain. The patient was afebrile and did not have significant pain with range of motion. Due to signs of superficial wound separation, the patient underwent wound debridement and closure under local anesthesia in the clinic setting. There was no purulence, and the wound was primarily closed with 3-0 nylons. A wound vac was placed on the wound, and the patient returned to clinic 2 weeks later for suture removal. So how do we break this down? So the question is surgical intervention versus clinical presentation. So what was the intervention? Well, this is the intervention here, right? The patient underwent wound debridement and closure under local anesthesia in the clinic setting, and the patient was told to monitor the wound for any signs of infection and hematoma. That's the intervention. This is the clinical presentation. Localized erythema, so that's an infection inflammation picture, wound separation, bruising and swelling, but there was no seroma. So what would be the letters for this patient here? D2, so there was some separation, and it was treated under local anesthesia. A, so wound separation. I1A, localized erythema, very minimal, and we had to monitor the wound. So the patient was told to monitor the wound, so that's I1. There was no seroma here, and then hematoma. There was localized erythema and bruising and swelling of the knee. So the bruising is hematoma, and then we did nothing. We just had the patient to monitor it. So those are the ways that you can break it down. So why does this matter? How does this make a difference? So let's say this patient came to your clinic, and you did this. You did a little local debridement, you put some 3O, you sent them home. Well, if the patient came to my clinic, and I took this patient to the theater, put him to sleep, and did a whole debridement, who cost the healthcare system more? And who cost the patient more? I did, right? Because I took him to anesthesia. So if I see your patient, and 1 year post-op, your patient's doing fine. And then 1 year post-op, my patient's doing fine, but I did a very invasive treatment, I should learn from you guys. You should tell me, you know what? You're fine. You don't need to take this patient to theater. I think of a person who's starting practice, for example. When I first started practice, I'd be very nervous. I take them immediately to the theater, right? Because I don't want to get in trouble. Well, the answer is you don't need to necessarily. And this will allow us to monitor patients over time and give us an outcome in all different realms. So the key factor is DISH is not a prescription on how your wound should be managed. It's in your hands, how you do it still. Again, the primary aim is not to say, did you do it right or do it wrong? The answer is, in a year from now, how's your patient doing? If your patient's doing as well as mine, then I should change what I do. So that's why we're thinking about this. So what does it also matter? So to reduce dehiscence, I use watertight closure. I use barbed suture. The type of closure, I use subcutaneous, and then dressings, something that seals and is occlusive. Reduce infection, use antimicrobial sutures and dressings to seal the wound. Reduce seroma, do again a watertight closure and compressive dressings. And then hematoma, I use hemostatic agents as well as compress the wound itself. So we need to optimize our patients prior to surgery. Your ERAS protocols are probably even better in depth than ours are. We need to use intraoperative methods to optimize our patients, and we need to monitor our patients after surgery so that we can change patient management to reduce bad outcomes. Thank you very much. Perfect.
Thank you, Dr. Anjana Chen, for we have mic on, please. Can we have lights on and chairs on the podium? So I'd like to request Anjana Chen, Dr. N.J. Karne, Dr. Kunal Bansal, Dr. Rajiv Nirvane, Dr. Avinash Pare for panel discussion. I'm going to throw some questions at you and maybe we can accept some questions from audience as well. So any questions from audience till we start our formal panel discussion? Anyone? Anirudh, do you have any question? Yes, Rajiv would like to. Yes. Yes. Yogesh. Mike. Yes. Can we have mic for the panelist?
I can talk a little louder.
Yes.
In infection cases, you're talking about. So the question is, how many samples do you send in infection cases? Always think of an odd number. So send a minimum of 3, typically up to 5. So it depends what case I'm doing. If I'm doing an DARE or IND and poly exchange, I typically only get 3 samples from it. If I'm taking everything out and I'm doing a 1-stage or 2-stage, I will actually go up the canals and get samples from there. I will get synovium, I will get the back of the knee, for example, or the back of the acetabulum if I can. So I'll get up to 5 samples if I remove the implants.
So all these cases, leaking wound, I mean, it's a nightmare for orthopedicians. And all these classifications we see, but any leaking wound, whether is a seroma or we call it serosanguinous discharge or hematoma. So even if we feel clinically there is no inflammation, but do you as a protocol send cultures for all these patients when you opt to close it with nylon, say?
No. So, and the reason is if you culture our skin here, we're all positive, right? And then you're giving them antibiotics, I think unnecessarily, honestly. So I don't actually culture. The only time I culture is if I go deep. If I go to the theater and I go in, then I always take cultures. Even for revision cases that are not infection, I will always take cultures because there is a high rate of infection revisions. But for the clinic one, I never send skin. And I never, sometimes they have an eschar, right? I never send eschar because it's always positive.
Always positive. I'd like to have, opinion of complete panel here, and then use of tourniquet in total knee. So yes, Dr. Karne, do you use tourniquet?
Yeah, I do use tourniquet because we are mentally set up for that. We use a tourniquet for that. Otherwise, for THR, we don't use a tourniquet, but still we do the cementing and all those things. But then we are tuned to use a tourniquet. But in India, the only reason which is given is either the skin vascularity goes down or the DVT is there. That is the two concerns for the tourniquet. In India, the DVT is not as that is in the Western countries. So,
but sorry to interrupt, sir, but that's a myth. I mean, so nowadays we are getting DVT, and we definitely need to go for aggressive DVT prophylaxis. Yes. So, although
especially the patient is having peripheral vascular disease or compromise the vascularity, then we can get rid of that. And some people do the in between that only during the cementing they use the tourniquet, and otherwise they don't use it.
Okay.
But till today, as the conventional teaching is going on, we are still using that and not yet repented.
Kunal, your view on this?
So if I'm doing a unilateral, if it's a fit patient, optimized patient,
What do you mean by fit?
The hemoglobin content is good, the transferrin is good, non-diabetic, non-immunocompromised, good host, single side, I do it without my tourniquet, completely, end to end. But if I'm doing a bilateral, I usually use the tourniquet.
Okay. Dr. Antonio?
So when I started practice, I used tourniquet for every case. And then I started using less and less because people were considering thigh pain and also the hidden blood loss, right? So once you let the tourniquet, all the blood loss comes in, and I couldn't get bleeders. So then I would apply a tourniquet, but not inflate it. And then one of my patients was, of course, the father of an anesthesiologist and said, I have horrible thigh pain, even though I didn't inflate it. So I said, no more tourniquet. So I just take a piece of foam tape, I wrap it around the thigh, and I almost never use tourniquet nowadays. So I actually, even if they're high, so I can get all the bleeders, I can see all the bleeders, and I can actually temporize them when I'm cementing. Now, I will say in the US, we do more cementless than we do cemented probably, so that makes a difference. But I leave the knee in flexion the entire time. I pulse lavage it, clean it as dry as possible, and then cement only in flexion to get the implants, and then go to extension and just keep it solid afterwards and no movement.
So what sort of, BP you ask for? I mean, is hypotensive anesthesia or, because otherwise we get a lot of bleeding on table during the procedure. And once the subacute orthotomy is done, the bleeding stops, but as soon as you complete your cuts, it starts again oozing from the cancellous bone.
So 2 things that I do that help. One, I definitely use electrocautery on the bleeders, but the cancellous bone is a big one. So that's where the Surgicel powder, like the hemostatic agents, have probably been one of the biggest changes in my practice to help try to temporize that amount of bleeding that's there.
Because uncemented knees, hips, we do it routinely uncemented, but uncemented knees are there on the horizon for India. I mean, they are entering in Indian market in a big way, very near future. So do you observe, are there any studies where this Surgisil powder or hemostatic powder affects the osteointegration of the uncemented implants?
So that's what the studies they need to do. You know, that's the one I do not know. I don't know the answer to that. In theory, what happens is it causes platelet aggregation, which actually causes clot, which is actually a good thing because that brings the growth factors to that location. So in theory, it should be good. I don't know if it's been studied or not. I think we've recommended that they do it in an in vivo setting, so like an animal model or something like that. But what I typically use it for, if you can use it on the bone surface, typically I'll put the implants in first and then use it on it.
Surrounding area.
Surrounding it. So, you know, like I try to get as much cancellous bone coverage for my tibia, for example. There's always a little bit of bleeding that happens there. But I put it more in the like posterior capsule, lateral geniculate, up and down the gutters, more than anything else.
Okay. Dr. Avinash, do you have any concerns with hypotensive anesthesia in TK? Because all of them are geriatric and with comorbidities.
No concerns at all if you maintain the mean arterial pressure above 60. So all the system perfusions remain intact. And then there are no issues even in laparoscopy, not orthopedic. Laparoscopic surgery, we give hypotensive anesthesia to all the patients and with very good results and very less blood loss.
Okay. How many of you, Kunal, Dr. Karne, Dr. Rajiv, I mean, do you use local tranexamic acid? Your view, Kunal, maybe you can start.
I always use it, sir. Especially
Arthrotomy.
after I've closed the arthrotomy, I will give a bolus of
Intra-articular.
Intra-articular, yes.
So
And
use parenteral also and then...
So one shot usually pre-operative,
Yes.
in the peri-operative time, and at the time of closure, after the closure is done, I put a dose of tranexamic acid and no drains.
No drains.
No drains.
Yes. So we have also stopped using drains since many years. And so do you, Dr. Anthony, that 048 hours regime for tranexamic acid, 10 milligram per kg, that's the dose you recommend or use for?
We don't, but there's good studies that show post-up day 1, post-up day 2, oral tranexamic acid.
048 hours.
048, yeah. People do it, we don't do it, and we found no difference.
So you use it only locally?
We only use it IV.
IV.
We do IV beginning of case, IV end of case, and that's it.
That's it.
That's it.
Okay. So you showed us, very good studies, comparison between the barbed suture, Stratafix we are talking about here, and barbed sutures as compared to Vicryl. So in India, we have cost constraints, to be very, honest with you. And then that's probably one of the biggest hindrance with this company people are facing here. And insurance companies, they don't cover. And that's the practical, issue we are dealing with. So are there any studies where for a total knee arthroplasty where we are used only for orthotomy closure versus orthotomy plus subcutaneous and then subcuticular with barbed? Are there any differences? Because then we can consider, because there are many centers, high volume centers, they are using only for orthotomy closure, and for other layers they use routine Vicryl.
So I think the answer is what problem are you solving for, right? So in our institution, if I can get a watertight closure in a faster time, so let's say I save 10 minutes. Well, 10 minutes is not going to be enough. But if I save 10 minutes over 5 cases, that actually gives me a time to put another case on. So from the hospital perspective, one more case is definitely worth the cost of the Stratafix. So we care about cost now too. They're trying to cut our costs down significantly. We just can't get anything we want, right? Insurance companies don't pay for it, the hospital pays for it. As a surgeon, I don't have to pay for it, but the hospital does. So they watch us. And so if I can cut the time down, that's a big thing. Then I can add more cases, the hospital's happy as one. 2, it's also the antimicrobial factor of it and the fact that you get a watertight seal. There's less returns to the operating room. That's less cost to the patient, less cost to the hospital. So while the cost of the suture is more expensive than Vicryl, the longer term impact of it is actually better, is what the studies show. Now, is there a difference if you do all the layers versus none of the layers? It's hard to say. At least for mine, with the adipose tissue, it just makes me bring the tissue better together. So it makes me feel better. When I do the Vicryl through adipose tissues, it just tears through. And so at least I get a better grip with the
Stratafix. Yeah. It's a no-brainer. Stratafix is definitely better, and you get a good grip with Stratafix as compared to Vicryl. And as far as, skin closure with mesh and a glue, so we have used it in hundreds of patients, but but our consistent observation, patient with low BMI, it worked better than patients with high BMI. Probably, I mean, your view on this, and should we, offer this closure option to patients with high BMI?
So I think the nice thing about mesh is that it seals better. I think you don't need it in every patient per se, but I do use it in every single one of my hips because I'm worried about the wound drainage. Because if they have the wound drainage and I have to take them back to theater, big problem, of course, right? So for the knees, though, I think it depends. It moves very well, which is good, but not every patient needs it per se. So if a lot of my knee patients, I can just do 3-0 and then put Dermabond on it. So just a Dermabond Advanced or a mini, the smaller one, as opposed to the big mesh dressing. So the mesh I typically reserve for my hips and Dermabond for my knees.
Okay. Any intra-articular these injections we gave for the pain relief. Do you have any experience of local steroid? Do you use it? I mean, earlier Ranawat cocktail, original Ranawat cocktail suggested that, and eventually they also stopped using that.
So we have the reason I'm laughing is two of my colleagues trained at HSS under Ranawat, and so they brought the Ranawat cocktail with them. So we use it, but only in patients undergoing manipulation under anesthesia. So if you get a manipulation because you have arthrofibrosis after a knee replacement, we will add the Ranawat cocktail, which means we add antibiotics to it too. So I don't love it, but we've so far been okay. But we do use steroids only for manipulation patients.
Okay, and use of adrenaline flush syringe in this local cocktail.
So we used to use ropivacaine, epinephrine, clonidine, and ketorolac. That was the 4 we would use because it was cheap, right? We use Exparel is a brand name one, very expensive. So we went for something cheap that our pharmacy could make. The problem if you have kidney disease, you can't use ketorolac, so we got rid of that. And then our patients were having orthostatic hypotension afterwards, so we got rid of the clonidine. So it's really just ropivacaine and epinephrine right now. It's basically a very mild local with some hemostatic agent to it.
Karne would like to say something on that.
Before closure, we don't use the steroids in the Ranawat cocktail, but we use the ropivacaine plus clonidine. And we inflate it all around the open capsule as well as the muscles are all around it, in the subcutaneous tissue also. It really helps to the patient post-operatively. Because what happens generally, in the fracture patient, before the surgery is pain far more, but after surgery the pain is felt is less. But knee replacement patient doesn't have the static pain. So post-op they complain a lot about the pain and they are not that happy. So we do use this cocktail, but not steroids, clonidine and ropivacaine.
Dr. Rajiv Nirvani is he's an eminent pediatric orthopedic surgeon, and he had a concern about whether this mesh with glue is it safe to use in a pediatric subset of patients. So any studies or anyone from Ethicon, any inputs from your side? Pediatric patient use of Dermabond in pediatric patients.
Certainly for orthopedics, we do have a number of surgeons using it for pediatrics, and there's studies of it being used in pediatrics, both in plastics and cardiac. Yeah.
Okay, and does it help in what we are talking about is primary wounds, but in revision surgeries, when there are already a scar and you have excised it, and does it heal the same way if you are using it in a revision case?
Did you want to respond to that?
Yes, you can. Yes.
I would say that in the revision setting, it's okay as well too, as long as the skin is well approximated. So what I always do is it's multiply revised. So let's say, like I get patients, you probably do the same thing with 10 revisions. Their skin is not good, and then it's not going to. So I don't use staples on this. I'm using nylons in those to bring them together. So it depends on how many revisions. If it's one revision, probably fine. I can use it in, but I don't use staples or nylons. I have to be able to run a subcuticular, and if I can do that, then I can use it for it. But it's not every time.
So you excise that scar in previous incision and then approximate, and then we can use this mesh and glue.
Correct.
So excise
Yeah, but I still have to be able to run a 3-0. If I can't run a 3-0, then I'm not using it. So I don't use it in every revision. Revisions I use either staples or nylons. like for the arthrotomy?
For skin closure, you're asking.
So I do interrupted 2-0 micro first, and then I do the running through. Yeah, I don't just rely on the 3-0. I do an interrupted 2-0 first.
2-0 first.
Yeah.
Yes.
I make sure
That's what we practice actually.
Yeah,
So.
I want it sealed as much as possible before that last step.
So for what's your preference for the TKRs with tourniquet, without tourniquet?
So, for brief period we shifted to without tourniquet, but that works actually without tourniquet. Tourniquet-less surgery is way to go. I mean that's how one should, less thigh pain, less atrophy. Quadriceps atrophy is less, and whatever bleeding is there, you can cauterize there on table. No hidden hematoma or bleeding. No surprises afterwards, and definitely less wound soakage post surgery, because then we release even if we release tourniquet, we don't release the tourniquet for before closure, after closure, and so we release the tourniquet after closure, after skin, or otherwise we release tourniquet, we cauterize. Still we don't get those bleeders, complete bleeders, and these patients, they develop soakage even if you do it, and the high chances as compared to tourniquet-less surgery.
You do use a tourniquet, but after putting the implant, before putting the poly, we release the tourniquet and cauterize everything. We spend around 15 minutes for that, thorough meticulous hemostasis, and then we put the poly. Because if you don't you remove the tourniquet throughout the surgery, is not good, because post-operatively you will have a lot of bleeding. So combination, you release the tourniquet just before putting the poly, have a good hemostasis, and if required, if at all there is some mild oozing from somewhere, okay, then we put it back again for a good closure.
That is, just to get sound sleep, that before putting the, some poly, you have deflated the tourniquet and there are no bleeders on the back side.
Atrophy because of tourniquet, it is less likely to get the tourniquet will cause a quadriceps atrophy.
No. I mean, there are reports, and lastly, I mean, see, there are reports about the blood loss. Blood loss. If you release the tourniquet before closure to cauterize, and you don't release the tourniquet, the blood loss is same. So, I mean, there is sufficient literature available where it says, I mean, it really doesn't make a difference as far as blood loss is concerned. But tourniquet-less surgery is way to go. That's what I feel. And
tourniquet is used in all other knee surgeries, trauma surgery, in all other surgeries. There is nothing different for the replacement surgery. And we don't find so many things there. If we are doing without tourniquets, I'm not against that. But tourniquet doesn't cause so much havoc that we should not use at all. That should not be the take-home message.
See, this ERA's protocols.
Arthroscopy, we have to use a tourniquet. I have seen the arthroscopy done without tourniquet. The bleeding goes on and they go on washing.
The shoulder we operate without. So that's without tourniquet.
There is no option, because that's why we are not using tourniquet. When there is an option, we can use it.
Yeah.
That is what we are saying. No? It's always the evolution, which is things coming into pictures over a period of time. The longer term results will appear, but any new concept is always thought from both perspectives.
There are quite a few high volume centers in India. They are using, I mean, they are performing TKI without tourniquet, and so that is individual choice. As far as, I mean, this current literature says, but these are our observations, which, and as far as this use of tourniquet, again, some of the very high BMI patients, it is very difficult to wrap that tourniquet cuff, and then you get that venous occlusion there, and then bleeding is much more than what you will face in tourniquet-less surgery. Okay, so anything from the audience? Yes.
There are two things to this, sir. The patients we are doing TK on are geriatric patients. Their musculatures are already compromised, whereas the trauma patients and the scopy patients usually have an intact musculature. So that is a differentiating point. And second thing is, the hemostasis around the knee is pretty predictable. So if you expose the knee, you know where the bleeders are going to be. So you don't need to wait for those bleeders to spurt up after you release the tourniquet. So that's also a big difference.
Yes. So there are strict contraindications where there is previous history of DVT. One should not use tourniquet. Secondly, you get to see those calcified vessels. There are reports where you see calcified vessel in the X-ray. You apply tourniquet. There are reports of fracture, vessel fracture in thigh. And then you, as soon as you release the tourniquet, or sometimes during procedure also you get sudden hypotension, your field is clear, you don't know, you're clueless about what is going on. So these two subset, or one should never use tourniquet. Okay. Yes. Yes.
What I feel is post-op management or the post-op exercises is the main recovery, you can say, or that is the reason why patients should get atrophy. Patient should not get atrophy within 1 or 2 hours of the surgery. Patient will not get the atrophy. Post-op protocol of the exercise, the earlier you start the exercise, patient will not get the quadriceps atrophy. Mobilization and the exercises.
Yes. Okay.
So you brought a good point about pressure. If I do have to use a tourniquet, I only go 100 above systolic.
Yes.
So I never go above 250 if I can help it, even down to 200 depending on how good our anesthetists are. So they keep it nice and low, it's great. So, yeah.
Okay. So that's it. I mean, thank you very much all the panelists for sparing your time and your inputs. ERAS, we keep evolving our concepts, and we are all, working towards improving those results and for faster recovery and daycare arthroplasty, which is a routine in US. And so, I mean, before we conclude, do you discharge your bilateral TKAs on same day, or you don't do bilateral TKAs?
So I do bilaterals. I had one patient go home the same day, one, but he was super motivated and he was ready to go. So he thankfully did very well. But I normally don't. So day surgery is only safe in a certain population. Not everyone can do day surgery. The drive of day surgery for us was two things. Number one, COVID. That was the biggest one. So when COVID happened, we couldn't operate on anyone who had to stay overnight. So the patient had to go home. And so I had my 85-year-old patient saying, I want surgery, so I will go home. And that became the norm then, right? And before that, everyone's like, I want to stay a few days. I don't want to go home. Okay. The second thing is our insurance company. So Medicare is our big insurance company that takes care of patients over the age of 65. And they took total hip and total knee off the inpatient only list, meaning that they encourage us to send them home the same day. So there is some insurance motivating drive as well too.
Okay, same thing is happening in India.
Unfortunately, sorry.
Okay, thank you very much.
Well, on behalf of Maharashtra Orthopedic Association, I really congratulate for having such a CME here, because most of the CME is only for the technique of the joint replacement or everything else. But the post-op management is equally important. Closure is equally important, because in most of the institutes, the closure is given to the residents, and they don't feel that is very important. But that is equally important, that of the surgery. Post-op management is equally important to that of the surgery, because if you climb the Everest and you cannot come down properly, there is still life can get threatened. So I thank and congratulate you and the Ethicon, and you came all the way from US. We are very much fortunate to have you here and your such a feedback. And this is one more golden feather in your diamond crown. You are doing so much academics, and we are proud of you. Keep it on.
Thank you.
Thank you.
So I take this opportunity to invite Anthony to our Pune Arthroplasty course, which will be conducting in first week of June 2027. I request Ethicon people, so if possible, because that will be a big show. And with MOA, I think we can have a separate session on ERAS there, because that is less talked in conferences, very extremely important, and you really, extremely important feedbacks and information for all of us. Antonio, thank you very much.
I have one question. So, as a part of ERAS, Dr. Chen, what is your take on adductor canal catheters? So, there's a lot of hope in the US, if I'm not wrong, even in Europe and Australia, to put adductor canal catheters, because these patients are the ones who usually land up going home the same day or the next day. Now, in India, we don't have that liberty of putting adductor canal catheters. So, what's your take on that?
I don't like them. So we don't use adductor canal catheter. We do single shot. I don't like we got rid of drains, right? So I don't want anything tethered. We use on-cue pump, was a pump that used to do it. They would break inside. It would come dislodged. I don't like those, honestly.
So one is your infection rates, and second is the complications.
The complications, yep. A single shot. And it works just as well, I think.
Better modalities are available.
Yes, there are much better modalities. Yeah, thanks.
Okay.
All right, thank you, everyone.
Yes.
Thanks.
All of you, please join us for lunch. Before leave. Yes, and workshop. Workshop and then lunch. Okay.